Good morning everyone. Myself Dr. Prashant Ramteke. Today I will take a lecture on acquired immunodeficiency syndrome. So acquired immunodeficiency syndrome is caused by a retrovirus which is called as human immunodeficiency virus, and it lead to profound immunosuppression, lead to opportunistic infections, secondary neoplasm and neurologic manifestation in the patients. So it's a pandemic, and most of the cases are from Asia and Africa. So this is the global distribution of the cases of HIV, where approximately 26% of the cases are from Africa, which is followed by Southeast Asia, America and other continents. Epidemiologically, where the study is done in the US, where they found the most common, most predominantly cases are the homosexual or bisexual men along with the IV drug abusers, which composed of approximately 62% of the cases. Apart from that, there are cases due to blood transfusion, which include hemophilic cases and a non-hemophilic recipient of blood and blood compound. So the major route of transmission of HIV is through the sexual transmission, which composed of more than 75% of the cases, followed by parenteral inoculation and passage of virus from infected mother to newborn. So sexual transmission is most common in homosexual male, where the virus is carried in semen, enter the recipient body through abrasion in rectal and or oral mucosa, or by direct contact with the mucosal lining cells. So the virus transmission occur in two ways, either by the direct inoculation into the blood due to trauma of the mucosa, or infection of the dendritic cell or CD4 positive T memory cells within the mucosa. The risk is enhanced by coexisting sexual transmitted diseases, especially associated with genital ulceration, and heterosexual transmission is the dominant mode of HIV transmission in Asia and Africa. Now the parenteral mode of transmission is commonly seen in IV drug abusers. Apart from that, hemophiliac and other recipient of contaminated blood transfusion are also the cases. However, IV drug abuse composed of the largest cases in parenteral transmission, which is due to sharing of needle syringes while using the drugs. An extremely small group through seronegative blood. So this is because of the awareness. So nowadays the health measures are very high, so the risk of HIV transmission through the blood transfusion is very rare. Then the another mode of transmission is mother to infant transmission. So major cause of pediatric AIDS are due to in utero transmission, that is transplacental spread, then during delivery through the infected birth canal, and after birth by ingestion of the breast milk. Intrapartum and peripartum transmission is most common mode of transmission. The rate of transmission by mother to infant transmission is 7 to 49% in different part of the world. This is depend on the risk factor as well as the treatment which is given to the infected mother, that is the HRT treatment, antiretroviral treatment. So the higher risk which lead to mother to infant transmission is high maternal viral load, low CD4 T cell count and chorioamnionitis during the pregnancy. However, as I said, with antiretroviral therapy, mother to child transmission has been virtually eliminated. So whatever cases we see of mother to infant transmission in the underdeveloped or poorly developed countries. So the HIV transmission cannot be transmitted by casual personal contact in the household, workplace or school. It is impossible of transmission of HIV by insect bite. However, after needle stick accident, the risk of seroconversion is about 0.3%. However, ART, antiretroviral therapy given within 24 to 48 hours of needle stick injury can significantly reduce the risk of infection. Now the structure and property of HIV. It is a retrovirus which belong to lentivirus family. Now there are two genetically different form but related form of HIV. One is HIV-1 which is the most common, and HIV-2 which commonly seen in West Africa and India. So this is the structure of HIV virus, where the virus core contain major capsid protein P24. So the importance of P24 is it is the most readily detected antigen of HIV, targeted by antibodies. Then nucleocapsid protein P7 and P9. This is the nucleocapsid protein around the P24. Then 2 copies of RNA and 3 important enzymes. These are protease, reverse transcriptase and integrase. So the HIV genome consists of 3 important genes, that is GAG, POL and N gene. The product of these genes are translated into a precursor protein which need to be cleaved by viral proteases to become a mature protein. And the anti-HIV-1 protease inhibitor, these are one of the antiretroviral component of antiretroviral therapy. They prevent the formation of this mature viral protein and lead to inhibition of replication and proliferation of HIV infection. Then other accessory genes are TAT, REV, VIF, NEF, VPR and VPU, which regulate and synthesize and has a role in assembly of viral particle and pathogenicity of the virus. The product of TAT cause 1000-fold increase in transcription of viral gene, which is critical for replication. Now it is known that the HIV genome is showing quite variability, and this variability is commonly seen in the genes which help in formation of the envelope of the virus. And because of this variability, which is due to the frequent mutation in the N gene, poses a problem for development of a anti-HIV vaccine. So HIV-1 can be divided into subgroups. One is M, major subgroup, other is O subgroup, which is outlier, and third is N subgroup, which is neither M nor R. And among these, M subgroup is the most common worldwide, and they are further divided into subtypes, which are from A to K, and their distribution varies geographically. B is the most common in Western Europe and US. However, A is most common in Thailand, and subtype C is the fastest spreading virus worldwide, and it's common and most common subtype in India. Now the pathogenesis of HIV infection. There are two major targets of HIV infection. First is the immune system of the body, and second is the central nervous system. So these lead to profound immunodeficiency, primarily affecting cell mediated immunity. So this is a hallmark of AIDS infection. AIDS and infection of and a severe loss of CD4 positive T cell lead to impaired function of surviving helper T cells. The other targets are macrophages and dendritic cells. So the life cycle of HIV, it composed of first the infection of the host cells, then integration of the provirus into the host cell genome, then activation of viral replication, and then production and release of infectious virus. So this is the diagram which illustrates the life cycle of the HIV virus. Here you can see first the virus bind to the host cells which are having the CD4 receptor. So the glycoprotein 120, it bind to CD4 receptor of the host, which lead to a conformational change in the glycoprotein 120, which lead to formation of the space for co-receptor. So for activation for penetration of the virus into the host, there is importance of the binding of virus to the co-receptor in addition to the CD4 binding. So only CD4 binding is not sufficient. The virus also need to bind to the co-receptors, and co-receptors mostly are the chemokine receptor, basically CCR5 and CXCR3. So when the glycoprotein 120 bind to CD4 and the co-receptor, chemokine co-receptor, there is again conformational change in the virus and there is exposure of this peptide in the virus, which lead to penetration of the peptide into the cell membrane and fusion of the virus. Once the virus fused with the host cells, the viral RNA genome, they enter the cytoplasm and they get converted into the complementary DNA, which is called as proviral DNA by help of reverse transcriptase, which is a enzyme present in the virus. So they remain in this cytoplasm as a latent period in the nevi T cells, or the cells which are not in the replicating phase. Once the cells get activated, the viral genome enter into the nucleus and it integrated with the host genome. So when there is cytokine activation of the cell during the activation of lymphocyte, there is replication, there is transcription of the HIV DNA, and this HIV DNA then transform into the formation of the HIV structure or HIV virus, mature HIV virus, which release out of the cell in the form of budding. So the infection of the cell by HIV is by using CD4 molecule as a receptor and various chemokine receptor as co-receptors. So the trophism of the virus for CD4 positive T cell and for the CD4 positive monocyte macrophage and dendritic cells is there. So binding of CD4 is not sufficient for infection, I said. The glycoprotein 120 must also bind to the other cell surface co-receptors like CCR5 and CXCR4. So based on this, based on the use of co-receptor, the HIV isolates, they are further divided into R5 strain which use CCR5 co-receptor for penetration, Then X4 strain which use CXCR4 co-receptor for penetration, and R5X4 strain which are the dual tropic strain which can use both the CCR5 or CXCR4 co-receptor for their penetration into the host. However, there are certain exceptions where if there is a polymorphism in the gene encoding CCR5, can see there is altered susceptibility to the HIV infection by the host. There are some studies where they found approximately 1% of the white American, they inherited the 2 mutant copies of CCR5 genes, and they are completely resistant to the R5 strain of virus, and about 20% of the individual are heterozygous. They have the 1 mutant copy, however the other allele is normal, and they are partially protected. In this case, even after the infection, the progression to the AIDS is delayed. Now, how the T cell depletion occur in the HIV infection? So, the loss of CD4 T cell is mainly caused by direct cytopathic effect of the virus due to replication. So, the possible mechanisms are increased plasma membrane permeability associated with budding of the virus particle. The other is defect in the protein synthesis stemming from interference by viral protein involved in viral replication. The other mechanism that may contribute to the loss or functional impairment of T cells is chronic activation of uninfected cell responding to HIV itself, or to infection that are common in individual with AIDS, leading to apoptosis of the T cells by the cytotoxic T cells. Then HIV infection of the cell in lymphoid organ cause progressive destruction and destruction of the architectural composition of the lymphoid tissue. The other way is fusion of the infected and uninfected cell lead to formation of giant cell, and these giant cell usually die within hours. And in addition, there is qualitative defect in T cell function, which in the form of reduction in the antigen induced T cell proliferation, decrease in Th1 type response in comparison to Th2 type, and defect in intracellular signaling. However, I can see that the virus can remain latent in the host cells for years, and this is the important feature of HIV infection. The integrated complementary DNA or provirus without viral gene expression can persist in cell for years or months. Even with potent antiviral therapy, which practically sterilizes the peripheral blood, the latent virus concealed within the CD4 positive cells in the lymph node and other lymphoid organs. Approximately 0.05% of CD4 positive T cells in lymph node are latently infected, and because of these CD4 positive T cells, which are predominantly memory cells, they are long lived with a lifespan of approximately a month to year, and thus provide a persistent reservoir of virus in addition to macrophages. So, there are other non-T lymphocyte cells of immune system which help in which are infected by HIV infection. The important one are macrophages, dendritic cells. So, macrophages, although the cell division is required for nuclear entry and replication of most retrovirus, HIV-1 can infect and multiply in a terminally differentiated non-dividing macrophages, which may contain large number of virus particles, and they are quite resistant to the cytopathic effect of HIV. So, they can remain in the remain and proliferate in the macrophage for longer period as compared to CD4 positive T cells. Then other is dendritic cells of the mucosa. They usually capture the mucosa by the lectin receptor and they migrate into the lymph node where they present the virus to the CD4 positive T cells. Also there are follicular dendritic cells which are also considered as a reservoir of virus. Now there are B lymphocytes which are also affected by the HIV infection, however they are not infected by HIV. So we can see a paradoxical spontaneous B cell activation and hypergammaglobulinemia in these cases. Despite the absence of spontaneously activated B cells, despite the presence of spontaneously activated B cell, patient with AIDS are unable to mount a required antibody response to a newly encountered antigen. This could be due to lack of T cell help which is needed for B cell activation, and also even the antibody response against the T cell independent antigens are also suppressed. So this indicate there might be an intrinsic defect in B cell itself. Now how the HIV infection lead to CNS involvement? So nervous system is the another major target of HIV infection, and the common cells which are infected in CNS are macrophages and microglia. Microglia are also the monocytes or macrophages in the CNS system. So here the neurons are not infected by HIV and the extent of neuropathologic changes is often less than might be expected from the severity of the neurologic symptom which is seen in the HIV patient. The neurologic defect is caused indirectly. The studies found that these neurologic deficits are caused indirectly by the viral products and the soluble factor produced by infected microglia such as cytokines, which include interleukin 1, TNF and interleukin 6. So how this is a natural history and the course of HIV infection, where you can see it is divided into the acute phase, then chronic phase, and then ultimately progresses into the acquired immunodeficiency syndrome. So in acute phase you can see the virus attached to the mucosal surface where they are taken up by the where they get bind to the CD4 positive T lymphocyte, and since most of these cells are memory T cells, CD4 positive T cells, so there will be a significant loss of memory T cells. In addition, the dendritic cells, they bind the virus through the lectin receptor and they transport this virus to the lymph node where they present the virus to the CD4 positive cells, and then the proliferation and replication of the virus occur in the lymphocyte and they systemically spread into the body, which is called as viremia. After that, the body develop a immune response in form of anti-HIV antibodies, and there is activation of cytotoxic lymphocyte, which are CD8 positive lymphocyte, which lead to apoptosis of the infected lymphocytes. So within 3 to 6 weeks after initial infection, approximately 40 to 90% of the infected individual develop acute immunodeficiency syndrome, which manifest in the form of variable non-specific symptoms like cold, fever, lymphadenopathy, diarrhea, and the seroconversion occur in the HIV patient usually within 3 to 7 weeks of presumed exposure. Now, what is seroconversion? Seroconversion is basically the formation of anti-HIV antibody in the host. So approximately 3 to 7 weeks are needed for formation of HIV antibody. So after the acute phase, there is chronic phase where the virus remain in the latent phase in the infected cells. In this case, the viral load in this phase, the viral load in the peripheral blood is low, and after 7 to 10 years, there is progression of the cases into acquired immunodeficiency syndrome, which is characterized by breakdown of the host defense and dramatic increase in plasma virus, and severe life-threatening clinical diseases. Typically, the patient present with long-lasting fever more than 1 month, fatigue, weight loss and diarrhea, serious opportunistic infections, secondary neoplasm and other clinical neurologic disease. These all form the AIDS indicator disease or AIDS defining illness. Now based on the progression of the disease of the HIV infection into the AIDS, based on the patterns, it is divided into 4 types. One is typical progressor, which are most common, and here the median survival time is approximately 10 years, and the progression into the AIDS take approximately 8 to 10 years. Then rapid progressor, these composed approximately 5 to 10% of the cases, and here the cases are rapidly progressing into the infectious cases. The HIV infection is rapidly progressing into the AIDS within 2 to 3 years, and there are also long term non-progressors where the infection do not progress to AIDS in the absence of antiretroviral therapy, and usually they show less than 5000 HIV RNA copies in the peripheral blood. And there are elite controllers. These are known as natural controllers, are the subset of large term non-progressors. Here the immune system, despite being infected with HIV, has been able to control successfully suppress the viral to an undetectable level for many years in the absence of ART. These cases predominantly composed of those cases which shows pleomorphism or the heterozygous allele for the CCR5 chemokine gene. Now CDC has classified various categories of HIV infection based on the CD4 positive T cell count, which is like this. Now the AIDS defining opportunistic infections includes the protozoal helminthic infection, which include cryptosporidiosis, isosporidiosis, toxoplasmosis. However, the characteristic of toxoplasmosis is it is the common mass forming, the infection lead to mass formation in CNS in the HIV infected cases in approximately 50%. Then fungal infections are Pneumocystis jirovecii, Candidiasis, Cryptococcosis, Coccidioidomycosis, Histoplasmosis. However, among these Candidiasis is the most common fungal infection in the AIDS. Then bacterial infection, which predominantly include the atypical mycobacterial infections, nocardiosis. Then viral infection, particularly cytomegalovirus, herpes simplex virus, varicella zoster virus and JC virus, which cause a progressive multifocal leukoencephalopathy in the HIV patients. Then there are some tumors which are seen in HIV patient. The common one is Kaposi sarcoma. However, this HIV, the opportunistic infection and the tumors associated with HIV are drastically reduced with the advent of antiretroviral therapies. Nowadays, these tumors are quite rare. However, in countries where the in the underdeveloping countries you can see the cases of Kaposi sarcoma. However, in developed countries the incidence is very low. This Kaposi sarcoma is caused by the herpes virus 8 and it is characterized by proliferation of spindle shaped cells which expresses the marker for both endothelial cells and the smooth muscle cells. So, the marker for endothelial cells are basically the CD34, CD31, ERG, FLY1, and the marker for smooth muscle cells are the SMA, desmin and caldesmon. The HHV8 herpes human herpes virus 8 infection is also associated with a rare B cell neoplasm which is also seen in AIDS patient, is the primary effusion lymphoma, and it is also associated with multicentric variant of Castleman disease. So, this is not associated with HIV infection, but it is associated with HHV8 infection. Then there are a list of lymphomas which are associated with HIV. The common one are Burkitt's lymphoma, approximately composed of 20 to 30% of the cases of HIV lymphomas. Then diffuse large B cell lymphoma, which include the primary CNS lymphomas and the DLBCL NOS cases. Then plasmablastic lymphoma, then primary effusion lymphoma, classic Hodgkin's lymphoma and HHV8 positive DLBCL NOS. Among these, the lymphomas which occur more specifically in HIV positive patient are primary effusion lymphoma, plasmablastic lymphoma and HHV8 positive DLBCL NOS, which are quite exclusively associated with HIV infection. Then other tumors include the carcinoma of cervix and the anal cancer, which are having the association with HPV infection. Now about the diagnosis of HIV. Let's see the curve of infection of HIV, where you can see a window period. So, window period is basically it is from the exposure to the HIV infection to the development of antibody into the host. So, in response to HIV infection, you can see HIV antibody in the host. You can see a complementary DNA of virus. You can detect the viral RNA copies. You can detect the P24 antigen of the HIV. So, the common screening test for HIV are ELISA and rapid or simplest test. Rapid test basically the kit test, where the antibodies are detected against the antigen. However, the sensitivity of these screening tests are very high, and they predominantly detect the IgG antibody. The detection time for ELISA is approximately 2 to 3 hours. However, rapid or simple test detect the result within 30 minutes. The other supplementary test has also detect the antibody, and they are quite specific compared to screening test, and they include Western blot test, immunofluorescence assay, radioimmunoprecipitation assay and line immunoassay. Then there are confirmatory tests for HIV infection, which include P24 antigen detection, viral culture, HIV RNA detection by means of reverse transcriptase, branch DNA assay, NAT, that is nucleic acid amplification test, and real-time RT-PCR. So, this is HIV RNA detection tests are considered to be the gold standard for confirmation of HIV infection. In addition, HIV DNA detection is also helpful in pediatric cases. Now the diagnosis of the diagnostic approach in the cases of pediatric HIV infection is quite different from the adult. In pediatric cases, the role of screening tests are not there. So, you cannot use the ELISA or rapid test to detect the antibodies in the pediatric cases, because you cannot differentiate between the immunoglobulin IgG anti-HIV anti-HIV IgG immunoglobulin. Are they belong to baby or they are transformed from mother? And the antibodies which the baby has from the mother, they take approximately 18 months to get disappear from the system of baby. And the recommended test for diagnosis of pediatric HIV include the HIV DNA detection, HIV RNA detection, P24 antigen detection, and the IgG ELISA only when the baby is more than 18 months of age. Then how to proceed in the case of HIV, which is in the window period. So window period, as I said, it refer to initial time interval between the exposure and the appearance of detectable level of antibody in the serum. So antibodies appear in the blood of the host within 2 to 8 weeks after infection, but they become detectable. They become at the detectable level after 3 to 12 weeks. So you can there are some tests like third generation ELISA which detect the antibodies averagely in 22 days. Then P24 antigen detection, which has the less sensitivity, and they can detect the P24 antigen averagely in 16 day of window. And HIV RNA detection, this is the best method and detect as earliest as on the 12th day of infection. Now there are certain tests which help in monitoring monitoring the prognosis of the HIV patient, which include the CD4 T cell count, which is most commonly done, then HIV RNA load, then P24 antigen detection, and neoterin and beta 2 macroglobulin level. Antibody levels are inconsistent during late stage due to immune collapse and hence are not reliable for prognosis purpose or monitoring purpose of the HIV patient. Thank you.